Welcome to today's lecture on the temporal region and the pharynx. In this first part, I will describe the temporal region, and in the second part, I will describe the pharynx. My name is Carlos Andres Suarez-Quian. I am the author and narrator of this piece. Let's start with a definition. Why call the side of the head the temporal region? As Pierce Brosnan demonstrates, customarily, gray hair first begins to show in the region of the temple. That is, we show the passage of time on this earth by the appearance of our hair. The size of our heads relates time. But even the second meaning of the word, relating to worldly as opposed to spiritual affairs, that is secular, fits well, because it is kept within our heads, in our minds. Here I list the objectives of this lecture. After I finish this lecture and you have a chance to review it, you should be able to define the following regions: the temporal region, the infratemporal fossa, the Pterygopalatine fossa or Sphenopalatine fossa, the temporomandibular joint, the pharynx, subdivisions of the pharynx, musculature of the pharynx, nerve supply of the pharynx, and finally the blood supply and lymphatic drainage of the pharynx. Let's start. The first thing we need to do is define the temporal bone, shown here in pink, and the bones with which it associates. The temporal bone consists of various parts. First, there is the squamous part, the zygomatic process, which helps to form your cheek that you can feel on your face, the mastoid process, that hard bump behind your ear. We're not born with it, but rather we develop it as we start to raise our heads. The sternocleidomastoid muscle, which attaches here, pulls on the bone, and in time we acquire the mastoid process. The last structure of the temporal bone we can see from this view is the styloid process, a needle-like structure, hence its name. Muscles and ligaments attach to this process. Several bones are in contact with the temporal bone that will contribute to our discussion for today. They include the mandible, specifically the ramus of the mandible, the maxilla or upper jaw, the zygomatic bone, the principal contributor to our cheekbone, and the sphenoid bone, specifically the greater wing of the sphenoid bone. Having defined the bone and the associated bones that make up the temporal region, let's now describe the soft structures we find here. We start by identifying a thick connective tissue layer known as the temporalis fascia that covers the muscle of the region, the temporalis muscle. We will define the action of the muscle in a second. We find an artery, the superficial temporal artery. We will see this artery as one of the terminal branches of the external carotid artery. And next, we discern the auriculotemporal nerve. Where does this nerve come from? We mentioned this nerve briefly in the cranial nerve lecture. It is a branch of the trigeminal nerve that exits into the infratemporal fossa, carries parasympathetic innervation to the parotid gland, then continues up into the temple to supply somatic sensory to the region. We will discuss this nerve again shortly. Having mentioned the infratemporal fossa in the previous slide, we now delve deeper into it and define its borders. And here, in the yellow circle, I show the region. It is the space below the temporal bone and deep to the ramus of the mandible. Let's again put some labels on the skull. And here they are. We again recognize the zygomatic process, the mastoid, the styloid, the ramus of the mandible, and the maxilla. But to truly appreciate the infratemporal fossa, the space indicated by the blue circle, we need to look at the skull after removing the mandible, as shown in the slide. And we can now define this region more precisely as below and deep to the temporal region, behind the maxilla, deep to the ramus of the mandible, and in front of the mastoid process. But we also see that the infratemporal fossa is defined medially by a plate, the lateral pterygoid plate. What is this plate? We now look at the sphenoid bone, a bone whose long axis is perpendicular to the long axis of the skull. Sphenoid means wedged in, and this bone is aptly named. It resembles a bat in flight. It is the wing-like structures that we have observed in the previous slide. For example, the greater wing of the sphenoid that articulated with the temporal bone, and the lateral pterygoid plate. Pterygoid simply means wing-like structure, hence its use in the name. We now see the infratemporal fossa from below and can now easily identify the bones: the temporal, maxilla, mandible, mastoid process, and the lateral pterygoid plate. You might have already noticed that there are several foramina that open into the infratemporal fossa. Remember, it is one foramen, but several foramina. Let's name them now. The oval foramen is called the foramen ovale, as opposed to the spiny-shaped foramen that is known as the foramen spinosum. The foramen through which the internal carotid artery enters the skull is known as the carotid foramen, and it's actually a canal. Finally, the foramen between the styloid and the mastoid processes is called the stylomastoid foramen. And here you thought the first anatomists were being creative in their naming of structures. I will go into what passes through these foramina in a little while. There's one last foramen to mention, the foramen lacerum, which I reserve for last. It too is appropriately named. Look at its jagged edge, and it would lacerate soft tissue coursing through here, hence its name. However, it is a foramen in name only, and only visible in a prepared skull as you see in the slide. In real life, there is a membrane covering this foramen, and only some minor blood vessels traverse this area. Having defined the area of the infratemporal fossa, we now need to discuss the structures found in this region. Specifically, I will describe the muscles, blood vessels, and nerves. Let's start with the muscles, and as a group, they are known as the muscles of mastication. First, we see the masseter. Technically, the masseter is not in the infratemporal region, but because it is a muscle of mastication, we include it in this group. The masseter helps to close the jaw and also helps protract the lower jaw. Next, we see the temporalis. Its broad expanse we already saw in the temporal region. It is a strong muscle enclosing the jaw. Clench your teeth and you will be able to detect your contracted temporalis muscle. Temporalis attaches at the coronoid process of the mandible, and this is what helps make it a powerful muscle enclosure of the jaw. It also helps to retract the lower jaw. To see the other two muscles of mastication, the lateral and medial pterygoids, the ramus of the mandible needs to be removed, as is now shown in the slide. The lateral pterygoid muscle helps with side-to-side movements of the mandible and also protraction of the lower jaw, and the muscle is located lateral to the medial pterygoid muscle. The medial pterygoid helps with elevation of the mandible, also side-to-side movements of the mandible, and with some protraction of the lower jaw. The lateral pterygoid muscle actually has two heads, but this level of detail is better left for the oral surgeons. Also, do not confuse the pterygoids with the buccinator muscle. The latter is a muscle of facial expression. Finally, in this drawing by Moore, the distinction between the medial and lateral pterygoid muscles can be truly appreciated. It also helps explain how the lateral pterygoid can help with protrusion and side-to-side movements of the mandible, whereas the medial pterygoid will help with elevation and side-to-side movement of the mandible. The muscles that we just discussed are, as a group, called the muscles of mastication. So what is mastication? Simply put, it is the action of chewing between the teeth and takes place because the temporomandibular joint, shown in the slide, allows for grinding between the upper and lower jaws. The temporomandibular joint is a modified hinge joint between the mandibular fossa of the temporal bone and the condyloid process of the mandible. Ligaments help keep the condyloid process within the joint capsule and help to stabilize the joint. These ligaments include the lateral, sphenomandibular, and stylomandibular. Let's now focus on the right-hand side of the image where the joint capsule has been cut open. Unlike most other synovial joints, where the articular surfaces of the bones are covered by a layer of hyaline cartilage, those of the TMJ are protected by fibrocartilage. And notice that the joint is completely divided by a fibrous articular disc into the upper joint cavity and the lower joint cavity. The lower part of the joint acts as a hinge, whereas the upper part allows protraction and retraction of the head. I hope that you did not know until this lecture that the temporomandibular joint can be dislocated. Forward dislocations are more common and occur when you open your jaw wide, like in yawning. And yes, it is generally very painful when this happens. Fracture of the mandible can also dislocate the joint. We now discuss the blood supply of this region, and it's very straightforward. In this image, the ramus of the mandible was removed to demonstrate the infratemporal fossa once again. The blood supply to this region is principally from the maxillary artery, one of the terminal branches of the external carotid, along with the superficial temporal artery. There are numerous branches that exit from the maxillary artery, but the only one I want you to focus on is the middle meningeal artery. This small branch exits the maxillary artery and enters the foramen spinosum into the middle cranial fossa outside the dura mater. This will be the source of an extradural hematoma if the side of the skull receives a hard blow. If this hematoma is not treated quickly, patient is likely to become comatose and die. Extradural hematomas in the skull are arterial in origin and quite dangerous. The maxillary artery ultimately becomes a Sphenopalatine artery and enters the posterior aspect of the nasal cavity. As one would expect, with a rich arterial blood supply in the infratemporal fossa, there should be present quite a few veins, and there are. But for the most part, we do not worry about them because if we know the arteries, we know the veins. One particular structure of clinical relevance, however, is the pterygoid plexus, shown in the image. Because this plexus drains also to the cavernous sinus in the head, infections in the infratemporal fossa may lead to intracranial infections and or damage to the nerves that travel through the sinus, for example, cranial nerves 3, 4, 5, and 6. Regarding the lymphatics of this region, I do not want to make light of them. As I mentioned during the introductory neck lecture, in general, lymph from the superficial lymph nodes will travel to the deep cervical lymph nodes located within the carotid sheath. That is really what you need to know for this course. If you pursue a career as an otolaryngologist, you will need to learn a bit more, but that can wait for now. But also, you should be aware of two very general concepts of how the lymph nodes themselves present in the neck. A soft, tender, and inflamed lymph node suggests an acute inflammatory process, which is most likely to be infective. Whereas firm, multinodular, large volume, rubbery nodes often suggest a diagnosis of lymphoma. Moreover, if you recall from the cranial nerve lecture, the four muscles of mastication are all innervated by the mandibular branch, V3, of the trigeminal nerve, cranial nerve 5. Injury to the nerve can be the result of trauma, tumors, aneurysms, and meningeal infections. And the key that something has happened to the nerve is that it will result in paralysis of the muscles, sometimes only one, sometimes all four of them, depending on where the lesion occurs. And the mandible will deviate and droop down to the side of the lesion. The drooping is simply the result of gravity. The masseter and temporalis are unable to close the jaws. At this point, we need to delve deeper into the nerves of the infratemporal fossa, and at first blush, this might appear somewhat overwhelming for you. But please bear with me, and in time, you will see that understanding these nerves and all that they regulate is truly quite manageable. Recall that the trigeminal nerve gives rise to three separate divisions: the ophthalmic, or V1, the maxillary, or V2, and the mandibular, or V3, that will provide sensory to three separate areas of the face, and V3 will also supply the muscles of mastication. Given that we're only concerned with the trigeminal nerve as it relates to the infratemporal fossa, we can eliminate the ophthalmic division from consideration in the field. Remember also that we have autonomic ganglia in the head, and three of these, the Pterygopalatine, submandibular, and otic, are of importance in this region, and these receive direct general sensory components from respective divisions of the trigeminal nerve. The Pterygopalatine ganglion receives general sensory from V2, whereas the submandibular ganglion and the otic ganglion are served by V3. We'll go into more details of how the autonomic nerves reach the ganglia in a second, but for now, let's finish identifying the nerves we see in the infratemporal fossa and what the nerves do. The first nerve labeled is a lingual nerve, a branch from the mandibular division of the trigeminal, and it will carry general sensation to the anterior two-thirds of the tongue. Now, this is not all that it does, but we will get more into all of its components when we introduce a parasympathetic modality into this region in a second. Next, we detect the inferior alveolar nerve, and this nerve is responsible for sensation of the lower teeth. Finally, one small nerve can be identified and labeled. It is the nerve of the mylohyoid. Understanding the location of the mandibular division of the trigeminal nerve and its precise distribution within the infratemporal fossa is the basis for why mandibular nerve blocks by anesthetist can be so effective in numbing the lower side of the face in order to perform procedures in this area. All this time we have been discussing the infratemporal fossa. Within this fossa, however, there's another space that is granted its own name, the Pterygopalatine fossa, and we will discuss this space now. And granted, you might think this is a bit of overkill on the part of anatomists to name a space within a space, but you will see in a moment why the Pterygopalatine fossa merits its own name. Let's name again the bones on the slide we have already learned. These are the sphenoid bone, the zygomatic bone, the maxilla, and the lateral pterygoid process. And now we can assign the name of the Pterygopalatine fossa to the space intervening between the two bones. But wait, that's not all. At the very tip of the fossa, there's an actual foramen, the Sphenopalatine foramen. And it is this foramen that marks the interconnection between the infratemporal fossa and the nasal cavity. Let's explore this connection some more. The top image is the image we just observed of the Sphenopalatine foramen from the outside. And in the center image, we see it from the inside on a bisected skull. To give you an idea of where we are, we have entered the nasal cavity from behind, and it's at the Sphenopalatine foramen that the Pterygopalatine ganglion sits. To demonstrate this in a cadaver, the mucosa from the perpendicular plate of the palatine bone is removed, the bone is cracked, and the Pterygopalatine ganglion appears. In this drawing, the Pterygopalatine ganglion is colored orange, and recall that the Pterygopalatine ganglion receives its general sensory from the maxillary division of the trigeminal nerve. Its preganglionic parasympathetic fibers, colored in blue, arrive there from the facial nerve. The parasympathetic nerve is called the greater petrosal nerve. And the postganglionic sympathetic fibers, colored in purple, arise from the sympathetic trunk and is called the deep petrosal nerve. What are the names of the postganglionic fibers from the Pterygopalatine ganglion called? In this coronal section through the ganglion, we identify the nasopalatine and the greater and lesser palatine nerves. The nasopalatine nerves will exit the ganglion, travel on the roof of the nasal cavity, descend down the nasal septum to exit at the incisive foramen to supply the hard palate. The greater and lesser palatine nerves descend down their respective canals in the palatine bone to supply the hard and soft palates, respectively. And why might you care to know about these nerves? Because these are the nerves responsible for hay fever symptoms. If you stay in this area long enough, you might be one of the lucky few who does not experience the joy of hay fever in the spring. The postganglionic fibers from the Pterygopalatine ganglion also return to the maxillary nerve and travel through the zygomatic bone via a branch known as the zygomatico-temporal nerve to join the lacrimal nerve. Bottom line, the Pterygopalatine ganglion is also responsible for tearing. Remember what I said in an earlier lecture. The cranial nerves are responsible for the demonstration of our emotions, good or bad, and that is why they're special. But now we think of Thanksgiving apple pie, and I don't know about you, but if there's a reason to come to America, it is for Thanksgiving and apple pie. What does this have to do with the cranial nerves? They're responsible for salivation, the first step of digestion. It turns out that two of the autonomic ganglia in the head regulate salivation, and here's the first one. The submandibular ganglion. Okay, so it is an autonomic ganglia. Let's go through the drill. It requires somatic sensory from the trigeminal, and what nerve will send somatic sensory to this ganglia? The lingual nerve from the mandibular division of the trigeminal nerve. Next, we must look for preganglionic parasympathetic fibers, and these arrive to the gland from the chorda tympani, that small branch we discussed previously that came from the facial nerve. We still need to deliver some sympathetic innervation to the gland, however, that is, for when we panic and our mouth becomes dry. We become dry mouth. Remember being called to the front of the room and you were unable to come up with the words to answer the teacher's questions? This is a modality of fight or flight responsible for this response, and the nerves responsible were bringing sympathetic innervation from the sympathetic nerves that had piggybacked onto the carotid arteries and found their way to the appropriate autonomic ganglion, in this case, the submandibular ganglion. We have one last autonomic ganglion to discuss in this region, the otic ganglion. Let's describe its regulation now. The otic ganglion, as shown in the previous slide and indicated in the drawing now, is just outside the foramen ovale. Let's now go through the exercise of describing what modalities are associated with this ganglion. General sensory is from the mandibular division. Preganglionic parasympathetic innervation is from cranial nerve 9, specifically the lesser petrosal nerve. This is the nerve that helps form part of the auriculotemporal nerve, the nerve that sandwiches the middle meningeal artery. Ultimately, if you become a neurologist, you will need to know a lot more about the salivation pathway. For this course, otic ganglion preganglionic innervation is by cranial nerve 9, specifically by the lesser petrosal nerve. As to sympathetic innervation, nerve fibers from the superior cervical ganglion get to the parotid gland to shut down your salivation. However, there are no specific nerves that you could identify with the naked eye, but realize that they exist, and if you ever experienced dry mouth, it was likely due to these nerves. This now concludes the first part of this lecture on the temporal and infratemporal regions of the face and skull.